A concussion, also known as mild traumatic brain injury, is a brain injury resulting from biomechanical force to the head. It consists of a complex set of pathophysiological processes which incorporate clinical, pathologic, and biomechanical injury. The injury may result from either a direct or indirect blow to the head and results in multiple symptoms that may include headaches, nausea, amnesia, balance issues, dizziness, and many more. The duration of these symptoms can range from hours to weeks. Research from the University of Pittsburgh Brain Trauma Research Center reported there are over 300,000 sports-related concussions annually in the U.S. alone, and playing a contact sport results in a 19% chance of sustaining a concussion each year. College football athletes have even a higher concussion rates, with a reported 34% suffering a single concussion and 20% stating they have suffered multiple. Despite the high prevalence rate, these statistics slightly underrepresent the true incidence rate due to diagnostic difficulties and underreporting. Concussions may result in a wide range of symptoms. Vestibular dysfunction after concussion will be the focus of our project. The vestibular system is located in the inner ear and divided into the peripheral and central components. Balance issues associated with concussions are believed to stem primarily from damage to the peripheral vestibular system, which is composed of the semicircular canals, otoliths, vestibular ganglia, and vestibular nerve. When properly functioning, the vestibular system integrates vision, muscle, joints, and inner ear organs, and results in an output from the brain that allows one to orient themselves in space. Damage to the system may cause numerous symptoms such as vertigo and dizziness to visual disturbances. Of these symptoms, the most common are dizziness, which occur 55 to 78% of patients, impaired balancing, occurring at 43 to 56% of the time, and blurred vision with an incidence of 49%.
The purpose of the study is to determine which vestibular rehabilitation currently used by physical therapists and healthcare providers will be an effective way to combat vestibular dysfunction in concussed athletes. In particular, we want to know which treatment will help the most people with a broad vestibular symptom profile rather than which particular treatments are best for which particular symptoms. We will attempt to determine which individual vestibular therapy will show the most overall improvement as determined by the difference in scores on the following concussion tests: the SCAT-3, the VOMS, the SOFT, and the MCT. We believe the statistical information will tell us which frontline treatment is most effective. However, just because one protocol emerges as the best treatment plan for a specific set of symptoms does not mean that it will be the best therapy for any symptom in particular. We hypothesize that the group receiving balance therapy will show the most overall improvement on the individual tests, and they will self-report the highest improvement in quality of life due to the universal importance of balance in everyday activities. Our study is composed of 3 types of vestibular rehabilitation: gaze stability, habituation, and balance exercises. Gaze stabilitation therapy in our study consists of 2 exercises. The first is green-walled eye movement. In this exercise, the patient closes one eye and a ball is placed directly in front of their visual field. The patient will follow the moving ball with their eyes without moving their head, and then the patient will follow the ball only by moving their head. The second exercise for gaze stabilitation is the VOR stimulation worksheet, which consists of navigating through a paper maze while following the direction of movement with one's head. Habituation is the next form of vestibular therapy. The concept of how habituation works is that an adverse physiological response to a stimulus will reduce with frequent recurring exposure to the stimulus. Our study incorporates 2 exercises, including shaking one's head back and forth while remaining stationary for 5 trials, and the second exercise is a knee-to-nose touch. Patients will be instructed to assume a seated position and touch their nose to their left knee for 5 trials. Balance training is the final form of therapy used in our study. 2 specific exercises will be utilized. First, patients will switch from a seated position to a standing position, and then will turn around and reach for an object. The second exercise consists of patients balancing with one foot on the floor for 30 seconds with their eyes open. This is then repeated with both of their eyes closed.
This study will utilize 4 tests specific to concussions in the vestibular system to assess patients' progress in their vestibular therapy. The 4 tests are the SCAT-3, VOMS, SOT, and MCT. The SCAT-3 stands for the Sport Concussion Assessment Tool 3. It consists of a self-scoring symptom evaluation, a cognitive assessment, also known as the SAC, a balance examination, and a coordination examination. The VOMS stands for Vestibular Ocular Motor Screening. The VOMS integrates vision, balance, and movement. It assesses 5 specific areas of vestibular and ocular systems, including smooth pursuits, saccades, vestibulo-ocular reflex, visual motion sensitivity, and near point of convergence distance. It was created to assess both vestibular and ocular impairments through patient-reported symptoms through a 5 to 10-minute screening. The SOT stands for Sensory Organization Test. Its purpose is to identify issues with postural control by assessing the patient's ability to make effective use of visual, vestibular, and proprioceptive information to maintain postural stability. During this assessment, the patients stand on a dual force plate system and undergo 6 different conditions, with each condition lasting 20 seconds for each of the 3 trials. A patient is then given an equilibrium score as well as a sensory analysis, which determines how much of the patient relies on the systems contributing to balance. The final test utilized in the study is the MCT, which stands for Motor Control Test. This test assesses gaze stabilization, habituation, and balance response following sudden, unexpected forward and backward perturbations of a support surface. A patient's ability to quickly and reflexively recover from these perturbations is then assessed.
For the methods of our study, 360 NCAA Division I athletes ages 18 to 25 from member colleges of the American Athletic Conference competing in contact and collision sports were enrolled in a study between August 2017 and August 2019. 180 of the participants, 90 female and 90 male, present with mild neurocognitive disorder consisting of all of the following symptoms: vertigo, dizziness, gaze instability, and imbalance for greater than 3 weeks as diagnosed by our interdisciplinary team consisting of physicians and physical therapists. The other 180 participants, 90 male and 90 female, are control subjects that present with no symptoms of mild neurocognitive disorder following sport-related mTBI. All athletes completed written informed consent forms, and the athletes were compensated for initial testing and again upon completion of the study sessions. Participants are divided into 3 groups of 120 designated as Group A, Group B, and Group C. Each group of 120 will consist of 60 participants presenting with signs of vestibular dysfunction secondary to sport-related concussion as diagnosed by a clinician, and 60 participants not presenting with signs of vestibular dysfunction secondary to sport-related mTBI. Treatment will be performed for all patients at the Tulane Institute of Sports Medicine at Tulane University by a physical therapist who is blind to the subgroup designations. Participants may discontinue participation in the experiment if at any time symptoms are aggravated by treatment. All other patients will perform their designated exercises 3 times a week over a period of 8 weeks. Group A will perform exercises specific to gaze stabilization rehabilitation. These exercises will be mediated by a physical therapist. Group B will perform exercises specific to vestibular habituation rehabilitation. Group C will perform exercises specific to balance training. To assess the effectiveness of each exercise, patients will take the SCAT-3, VOMS, SOT, and the MCT. They'll take these 4 tests before the 8-week experimental period begins and again after the 8-week experimental period ends. Additionally, patients will complete a self-reported survey rating the improvement of their symptoms as well as changes in overall quality of life before therapy and after therapy.
We believe all control groups will do well on the first round of tests and will ultimately show improvement due to familiarity and practice. The concussion groups will vary with their initial performance due to injury. For SCAT-3, Group C1 should show the most improvement, followed by Group B1 due to the crossover of balance and nose-to-knee components respectively on SCAT-3. For VOMS performance, Group A1 should show most improvement because gaze stabilization relevance in the VOMS test. Group B1 will also show improvement because of the vestibular habituation crossover with the VOMS test. For MCT performance, we expect all groups to all show large improvements because this test allows you to test either vestibular habituation, gaze stabilization, or balance while controlling for the other 2 factors.
SOT, we expect Group C1 to show massive improvement due to high relevance of balance in the SOT, and we expect Group A1 to show some improvement due to some crossover between gaze stabilization and the SOT.
Overall, we believe that Group C will show the largest improvement overall because they showed the most improvement on the most tests, followed by Group A and lastly Group B. Group C showed massive improvement on 3/4 of the test. Balance is crucial for day-to-day activities as well as sports-related and occupational function. For these reasons, we believe balance rehabilitation should be recommended as a frontline treatment for vestibular dysfunction following concussion. In other words, this should be a default treatment for all concussion patients complaining of vestibular symptoms, but other rehabs should be added on a patient-to-patient basis depending on other specific complaints. One possible issue in this study design is that we picked 4 tests based off of the recommendation of concussion literature. However, there are many more tests to be studied, and concussion cannot be diagnosed with just 1 test. For this reason, there is a possible area of improvement being shown for Group C simply because of the particular test being used, not because of balance training is the most helpful rehab. Future studies include using individualized treatments for each patient displaying with specific symptoms and testing them before and after with the 4 tests used in this experiment and cross-comparing the results with our study. Other concussion tests should be evaluated along with the 4 in our study to see how improvement on these tests compare with various exercises.